Thank you for the President and the Council of the Nawalapitiya Clinical Society for giving me this opportunity to deliver this lecture today. If I talk about the topic today, usually if you when you hear the name of the microbiologist, you will just remember mostly about the antibiotic resistance, antimicrobials, or infection control, may sometimes even about hospital-acquired infection. So I thought I should go beyond our usual norm today and should talk about a different topic. We microbiologists actually usually manage wounds, especially me because I have some special interest over it, but we hardly talk about this topic to an open forum like this. Because of that, I decided to talk about wound care today. And as you all know, this wound care is highly multidisciplinary. But because I am a microbiologist, I decided to discuss with you all today about the clinical relevance of microbiology in wound care. The topic today is wound care, microbiologist perspective. What is the wound? A wound is a defect in an organ or tissue. Why we are worrying about wounds? Because a chronic non-healing wound is a lifelong suffering. They have estimated that the global prevalence of wound is 1.51 to 2.21 per thousand population. If you go through these two wounds, you can understand. You may have understand how suffering is a chronic wound. That's why I told it's a lifelong suffering. So the main reason for me to make a true interest on this area is a chronic diabetic wound, and the other one is a wound associated with chronic osteomyelitis. If a person is suffering with those type of wounds, it's definitely a lifelong suffering. Burden of wounds in Sri Lanka. They have found that 1 into 8 adults in Sri Lanka has diabetic mellitus. Prevalence roughly estimated about 10 to 12%. I think Sonali will give definite data about this. And what they told is about 45% of them have ulcers. That prevalence of diabetic wounds in a given time is estimated about 100,000. 1/3 of them will lose their leg because of this chronic diabetic ulcers, and half of them have died in 3 years. So they found that new diabetic wounds per year is diagnosed around 40,000. So then you can understand these wounds are a big burden not only for our country, any country in the world where diabetes is so prevalent. Nowadays it's like an endemic disease. Wound types. As you all know, there are two types of wounds, the acute wounds and the chronic wounds. Acute wound derived from an unexpected accident or surgical injury commonly heal within a predictable period depending on the size, depth and extent of damage, such as surgical wounds, bites, burns and minor cuts and abrasions. A chronic wound, a wound that is failed to proceed through an orderly and timely reparative process to produce an anatomic and functional integrity within a period of 3 months. That means if the wound doesn't heal within 3 months, and if it go beyond the 3 months, we call it as a chronic non-healing wound, like leg ulcers, foot ulcers, pressure sores, and the diabetic wounds. This is, you can see the difference clearly, the acute wound and the chronic wound. Then you can understand how the chronic wound is a suffering for the patients and it's a burden for the hospital and the country. Wound healing. So everybody we should know about wound healing, because if there's a wound, we always think about the healing of the wound. Wound healing is a repair or reconstitution of a defect in an organ or tissue, commonly the skin. There are 4 stages involved in wound healing: hemostasis phase and inflammatory phase. Both these phases are involved with cellular response, that is migration of macrophages, T lymphocytes, mast cells and neutrophils to the site of the wound, and they secrete several inflammatory markers which needs for healing. Then the proliferative phase. If the wound is in the proliferative phase, we are happy because it always promotes healing. That is, in this phase, there's good blood supply, resistant to infection, no need systemic antibiotics at this stage, and can manage with topical dressings at this stage because the healing is always progressing at this stage. Remodeling, the last stage, take the shape of the rest of the skin. Factors impair wound healing. There are two kinds of factors, local factors and the systemic factors. The local factors are ischemia, infection, foreign bodies, edema, pressure, venous insufficiency, and neuropathy. Because I am a microbiologist, during the rest of the lecture I concern more about the infection as a cause of impaired wound healing. The systemic factors are age, diabetes mellitus, malnutrition, because these elements, protein, zinc and vitamin C, needs inadequate amount to have a better wound healing. Uremia, jaundice, carcinoma and steroids. Because those which can lead to immunosuppression. Then I will move more on to my topic, that is wound microbiology. From the microbiological point of view, the primary function of the normal intact skin is to control microbial population that live on the skin surface and to prevent the underlying tissue from becoming colonized and invaded by potential pathogens. Wound results exposure of subcutaneous tissue from a loss of skin integrity. Then what has happened is this discontinuity of skin provides a moist, warm and nutritious environment that is conducive to microbial colonization and proliferation, which expose the host to infections. That's why when there's a skin breach, they tend to get infected. Factors that influence abundance and diversity of microorganisms in any wounds. Mainly the type of wound, whether it is acute or chronic, and the depth of the wound, whether it is a deep wound or a superficial wound. Location of the wound according to the involved body sites, because some sites there are normal our microflora which prone to get infections more. Quality of the wound. Microflora associated with clean surgical wound is minimal, and the presence of foreign material and devitalized tissue in a traumatic wound is likely to facilitate more microbial proliferation than a clean surgical wound. So those wounds tend to get infected more than the clean surgical wounds. And the level of perfusion to the wound. Hypoxia, anoxia results by impaired arterial blood supply due to peripheral vascular disease, or impaired venous drainage results by varicose veins, which always allow the migration of these immune cells of the immune system will derange because of the poor perfusion and will promote growth of microorganisms. And the antimicrobial efficacy of the host immune response depends on the certain predisposing factors like diabetes, immunosuppression, and advanced age, obesity, smoking, poor nutrition. All these count for a poor immune response, which results in the reduced antimicrobial efficacy of our own immune system. Bioburden of the wounds. Bioburden is the microbial flora of the wounds. Results by the interaction between the wound and the bacteria. It's stratified into 4 levels. This bioburden of the wound is stratified into 4 levels: the contamination, colonization, critical colonization, and infection. Then contamination. Contamination is by microbes. In contamination, that means wound is just contaminated with microbes. By microbes in this situation are not believed to inhibit healing. They just stay over the wound surface, but they doesn't cause any problem associated with healing. Microbial colonization. I think you all may heard the word colonization a lot of time, but sometimes you may not have a proper idea what is the true colonization of the wound. Because it's very important to know, you have to identify whether this wound is colonized or infected to go ahead with the proper management. That's why I included these things in detail, which you may have a poor idea about how to differentiate and what is the difference. Microbial colonization, even that not believed to inhibit healing, because bacteria in this colonization state multiply in the wounds but not damage natural tissues. Wounds first get colonized with the microbial contaminants originated from three main sources. First one is from the environment, exogenous microbes in the air or those introduced by traumatic injury. The second from the surrounding skin, involving members of the normal skin flora, such as the organisms in our normal skin flora, Staphylococcus epidermidis, micrococci, skin diphtherites, and propionibacteria. And third one is the endogenous sources involving mucous membranes. We know that our organs are usual systems involve a certain type of own microbial flora. So these endogenous sources result in breaching to these systems can cause wounds colonized with endogenous microbial flora, such as primarily the gastrointestinal, oropharyngeal, genitourinary mucosa, which all these areas have our own microflora. Both acute and chronic wounds are susceptible to contamination and colonization by a wide variety of aerobic and anaerobic organisms. So this contamination, not only for a certain specific organism, it's a huge polymicrobial nature. It varies from either aerobic, anaerobic, or can be both. Then the next stage is the critical colonization. This term have to be carefully assessed because the term critical colonization has been used to describe the stage at which bacteria begin to adversely affect wound healing. And this is the stage we have to intervene urgently to prevent wound getting into chronic stage, because at this stage the wound getting bigger and it results tissue damage. Then the fourth stage, wound infection. The line between the colonization and the infection can be difficult to define. That's why I told we need to carefully identify those two stages. The distinction between infected and colonized wounds has to be considered on a clinical basis and not by microbiological analysis due to the universal colonization of wounds. Anyway, there's a skin breach. If the underlying tissue is exposed, they first get contaminated, then colonized. So you can't detect by doing microbiological analysis whether this wound is colonized or infected. It has to be defined on clinical grounds. The wound should be considered infected when there are purulent secretions or the presence of two or more signs of inflammation like erythema, warmth, tenderness, heat, and induration, or if one of the following symptoms are present: pyrexia, increased pain, increasing erythema of surrounding skin, lymphangitis, or rapid increase in ulcer size. Chronic wounds, by their very nature, may not always display the classic symptoms of infection. Sometimes chronic wounds, it will be there for like this, but suddenly it get infected. So you should know at what time the chronic wound is turned to an infected stage. The following features should be employed to identify infection in such chronic wounds: serous exudate plus concurrent inflammation, and if there's delayed healing, discoloration of the granulation tissue, fiber granulation tissue, foul odor, and wound breakdown, which indicative of chronic wound is going into the stage of infection. I told you about all the wounds are colonized, but not all wounds are get infected. If you see this wound, this is a colonized wound, and we saw this wound, and have you seen the culture plate? It grows a certain amount of bacteria. It's a coliform. It's grown well nicely all over the plate, around 3 plus. But this is the wound. If you take the next wound, and this is the infected wound, but still you have seen the same amount of microorganisms have grown in the culture plate. That's why I told, by doing microbiological culture and culture, you can't differentiate whether this wound is colonized and the infected. Because colonized wound, you don't want to treat with systemic antibiotics. Even though you treat, it will not get any benefit to the patient, only allowed through the development of resistance. But the second wound, infected wound, definitely you need proper surgical debridement and you need systemic antibiotics. That's why I show you the difference. This wound is colonized wound, still has microbial flora on it, and the second wound, which is infected, still has microbial flora. The previous one is a coliform and this is a Klebsiella grown, but in the same amounts. That's why I told whether it is colonized or infected, you have to define by the clinical grounds. Therefore, the presence of microbes per se is not indicative of wound infection. It's very important for you all to know. The presence of microbes per se is not the indication for wound infection. The factors predisposing to microbial proliferation, blood, as I told you earlier, blood perfusion to surrounding wounds. If the tissue oxygen concentration is more than 40, healing is extremely good. And if the tissue oxygen tension is less than 20, healing is unlikely. Because the delivering of oxygen, nutrients and the cells of the immune system to the site of the injury and providing minimal opportunity for microorganisms to colonize and proliferate. Because if there's good blood supply, it provides all the nutrients and cells of the immune system and prevent getting microbes colonized there. The oxygen is a critical component of the respiratory burst activity in the polymorphonuclear leukocytes, resulting in the intracellular production of highly potent antimicrobial metabolites. This polymorphonuclear leukocyte is neutrophils is a key mechanism involved in wound healing because they migrate to the site of the wound and it involves mainly in wound healing. It produces intracellular protein antimicrobial metabolites which act against the pathogens. But if there's poor perfusion, this migration of these cells will not occur properly. Because of that, for even it doesn't occur properly, for their respiratory burst activity which results in the production of these potent antimicrobials will occur in the presence of adequate amount of oxygen. So oxygen delivery to the site of the wound environment is very important for to go ahead with the process of wound healing. And the presence of necrotic and devitalized tissue caused by tissue hypoxia or anoxia. It creates an ideal growth condition for the members of the wound flora. Fastidious anaerobes that will proliferate as reduced oxygen is consumed by the facultative bacteria. Low redox potential will facilitate development of aerobic and anaerobic population. What will happen is when there is organism, they used to take oxygen from the environment, which create certain areas in the wound, these anaerobic areas. When there's low redox potential, which what we call is these fastidious anaerobes. That means they grow in reduced oxygen tension, not the totally zero oxygen tension. When there's reduced oxygen tension, these fastidious anaerobes grow. Then they will use oxygen more and more. Then what will happen is, so microbial flora in wounds, especially chronic wounds, are polymicrobial, includes aerobes, facultative anaerobes and the fastidious anaerobes. What will happen? When first the aerobes take oxygen, then they produce a reduced oxygen potential, then the fastidious anaerobes grow, which grow in the reduced oxygen tension, and when they use oxygen, then there is the areas where there is no oxygen at all, then the what you call the fastidious anaerobes. That means they need totally oxygen free area to grow, then we started growing. Then this wound microflora will be highly polymicrobial with aerobes, facultative anaerobes and the fastidious anaerobes, not only one type of organism. That's why it's very disastrous when it comes to this stage. So this necrotic and revitalized tissue always act as an nidus for bacteria. Bacteria, they are produce metalloproteinases which damage the surrounding tissue, and also they compete with normal tissue for oxygen. Anyway, they reduce the oxygen tension. And other factors are the presence of foreign material, because it tends to form biofilms, and in the biofilms these bacteria will nicely stay inside the biofilm, and this penetration of antibiotics to the biofilms are very poor, and they nicely stay within, they live happily within the biofilms. They exchange messages between microbes inside the biofilm by a special mechanism called quorum sensing mechanism. So with that, they as a population, they stay there within the biofilm unless you physically remove. Sometimes physically remove the foreign material, you can't treat it. And the presence of slough and pus, they also act as a nidus for bacteria. And microbes and wound healing. The majority of dermal wounds are colonized with both aerobic and anaerobic microbes. So microbial population of the wounds, as I told you, are mostly polymicrobial. In the event of an established infection, a wound fails to heal. But the precise interaction between the microbes in the wounds and the impaired healing is unknown. The role and the significance of these microbes in wound healing has been debated for many years. Possible microbiological factors interact with wound healing on continuous debate over several decades. As you know, when there's established infection, wound is definitely failed to heal. But how these microbes interact with wound healing is debated many years, but there's still no definite theory on that. There are so many theories, still we are debating on that, how this occurs. But we know it's definitely happened. Microflora associated with the clean surgical wounds are minimal. So primary closure, only primary closure is enabled to progress the healing naturally and quickly, because there's only a minute amount of microflora there. So the primary closure of the wound itself is enough. But if it is a more severe traumatic wound, the presence of devitalized tissue and the contamination with bacterial and non-viable foreign material is likely to require surgical debridement and antimicrobial therapy to enable healing to progress through a natural series of processes. But it is a contaminated wound. You have to remove all the devitalized tissue and whatever the foreign material through surgical debridement, and you need to give antimicrobial therapy according to the culture and ABST to push it through the natural process of healing. So it is very important to know, that's why I highlighted in red, any wound is at risk of getting infected at any time. And microbial population in wound environment, we call it wound microflora. There's a special concept called wound microflora. So that is a microbial population stay within the wound environment. What are the possible factors interact with wound healing? I mean with regard to wound microflora. One, the main feature they have found out, I told there are always debates are going on. We don't know what is exactly happened, but there are some theories. These may be a possibility. But there's one good theory that they told the critical bacterial load. The bacterial load in the microflora, wound microflora, has critical effect on wound healing. They found that non-healing is associated with a bacterial load of more than 10 to the power 5 bacteria per gram tissue. And other factor is synergistic relationship between bacterial species within the wound microflora. That is, increase the net pathogenic effect and hence the severity of infection in several ways. I will explain in a minute. Oxygen consumption by aerobic bacteria induces tissue hypoxia and lowering the lowering the redox potential, which favors the growth of anaerobic bacteria. What they say is, I will explain you later. The specific nutrients produced by one bacterium may encourage the growth of fastidious and potentially pathogenic cohabiting microorganisms. Some anaerobes are able to impair host immune cell function and thus provide a competitive advantage to themselves and other cohabiting microorganisms. What they say is, I told it's polymicrobial. Different type of organisms are there. So one type of organisms, as I told you, take oxygen. So it will favor the environment for organisms with low oxygen tension. And some bacteria, they produce nutrients. That nutrients actually they don't want, but they produce for the sake of the other organisms to survive. So when one bacteria is producing nutrients, and with nutrients another cohabiting organism survive in the microflora. And sometimes some bacteria they inhibit host cell immune function. So then it will allow themselves to stay there, as well as it provides advantage to other cohabitant microorganisms there also to survive. That's why we told there's a synergistic relationship between microorganisms in the wound microflora. If I give you an example, Staph aureus induce growth and virulence in the pigmenting anaerobes, providing an essential growth factor. This antiphagocytic activity in Prevotella melanogenica was expressed only in the presence of hemine and vitamin K provided by cohabiting microorganisms. That is, this Staph aureus, you know, they produce two factors X and Y, and hemine is one of these factors. But this Prevotella melanogenica is a fastidious anaerobe which has our stay in our normal flora, and it also a cohabiting microorganism in venom wounds. They induce their antiphagocytic activity. That I told the neutrophils are the main combating mechanism in the wound environment. So this antiphagocytic activity engulf neutrophils. This activity of prevotella is occur in the presence of hemine and vitamin K. And hemine is provided by the Staph aureus, which is stay in the same wound environment. That's why I told there is a synergistic relationship. So if I tell you that what we think is for us to survive, we don't know that unity is the main component of survival. Sometimes we humans, we always think if we want to survive, we have to kill the other person, or we have to be more powerful than the other person for us to stay. But these little tiny little creatures, they are very genius and very mindful than us. They know if they want to survive, they have to help each other. Then they can nicely survive. That is what happens in wound environment. That's why it's very difficult to remove wound microflora from that environment, because they nicely helping each other and stay in a peaceful manner, not like humans. We fight each other and we kill each other for us to become powerful. But they will never ever kill anybody. They always think, if I want to survive, I want to help my colleague. If both of us will be there, only we become more powerful. So they are very tiny little creatures. We can't see through our naked eye, but they are very genius in that case, and where they are very smart. That's why I love them, actually, being a microbiologist, because of their great quality, which most of the human doesn't have. The presence of specific pathogens like Staph aureus, Pseudomonas aeruginosa, beta hemolytic streptococci has been most frequently cited as the cause of delayed wound healing and infection. These are, of course, true pathogens. There are two pathogens, opportunistic pathogens, emerging pathogens. There are different kind of pathogens, but Staph aureus, Pseudomonas aeruginosa, and the beta hemolytic streptococci, if you found in the wound, they are definite pathogens. They definitely cause delayed wound healing. And wound types and common pathogens. I didn't go into detail because if my lecture is not completed if I just give a brief idea about what sort of microorganisms are prevalent in different wound types. Surgical wounds. Actually, surgical wounds, the risk of infection is generally based on the susceptibility of surgical wound to microbial contamination. Usually, the risk of wound infection is very less if you do the surgical technique properly. What they say is clean surgery carries only 1 to 5% risk of post-wound infection, and dirty procedures more susceptible to endogenous contamination results 20 to 30% risk of infection, and they are always polymicrobial, and these are the pathogens involved in surgical site infections, commonly Staph aureus, E. coli, Pseudomonas aeruginosa, and the other pathogens as I mentioned here. And about acute soft tissue infections, Staph aureus being the most commonest isolate, and then the Streptococcus pyogenes, that is group-based streptococci. And about bite wounds, if you may not have thought about, bite wounds can carry a risk of wound infection significantly, human as well as animal bites. They are actually due to the complex nature of oral microflora in both humans and animals. Associated with bites has a polymicrobial etiology with the aerobic and anaerobic flora. These bite wounds always get infected with the microflora of the person or the animal the bite occurs. So usually our microflora in animals and ours is both aerobic and anaerobic mixture. So these bite wounds, always the etiology is polymicrobial. And the burn wounds, they have found the major complication in burn wounds is the infection, and up to 75% of deaths following burn injury are related to infection. And the most prevalent pathogens are the Pseudomonas aeruginosa, Staph aureus, Escherichia coli, and the Klebsiella species. There are the rest of the pathogens as well. And diabetic foot ulcers. This inability of the polymorphonuclear leukocytes to penetrate the tissue to deal with invading microorganisms effectively because of the poor blood supply. These macrophages, they penetrate less to the tissue, which allow microbes to invade effectively. The most prevalent is Staph aureus and other, as mentioned, the Streptococcus species, Pseudomonas aeruginosa, and the Enterococcus species. And mainly the commonest pathogen identified is the Staph aureus. And the decubitus ulcers, these are the pressure ulcers. They told approximately 25% decubitus ulcers are associated with underlying osteomyelitis. Unless you correct that, these wounds will not get healed. And predominant isolates are Staphylococcus aureus. Bacterial species is the main anaerobe in our own flora, and Pseudomonas aeruginosa. Then other important part in wound management with regard to microbiology is the proper sampling. If you don't know, if you think when you send a wound swab to us, we will send you a report telling coliform isolated, Staph aureus isolated. You may think that we grow only that organisms. If you come to the lab and see how difficult we are isolating the true pathogen, because if you don't take the proper wound swab, I told it's always polymicrobial. There is lot of there's several types of microorganisms are there in the wound flora. It's not one organism. So when you just swab the wound without taking properly, when we culture it, we go several pathogens, sometimes 4 or 5 types. Rather than giving a mixed growth, I always ask my MLTs to try and subculture again and again to separate the pathogen and issue your report. You may think because we are give you one pathogen, maybe only one pathogen growing, and it's very easy task for us. It's very difficult to deal with these samples from wounds. I think you may have an idea. So it's highly polymicrobial. Lot of organisms are there. They don't all are having the same probability of being the pathogen there. They just say contaminants, they just say as colonized. So we have to find the true pathogen and giving you the true report for treat only for them. Otherwise, if not, the wound doesn't heal. You will understand when I go on about it more. For the routine management of wounds, these are the indication for you to take samples in wounds, not all the wounds necessary sampling. So for the routine management, if there's a presence of a devitalized acute or chronic wound or clinically infected wound, if the acute or chronic wound, it associated with devitalized tissue or clinically infected wound, should be sampled for microbiological analysis. And also, even though there are no clinical signs of infection, but the wounds are deteriorating, like diabetic foot ulcer, or have a long history to failure to heal, then that wound is also warrant sampling. And these samples needs to obtain aseptically, because I told anyway already microflora is there. If you added more organisms by not taking proper aseptic condition, then we are in more trouble, because so many organisms are growing on top of the organisms they are in the own microflora. The type of samples, this is also very important for you to know what type of samples you should send for microbiological analysis. Mainly the wound tissue sampling, acquisition of deep tissue during biopsy following initial debridement and cleansing of superficial debris is recognized as being the most useful method for determining the microbial load and the presence of invasive pathogens. When we ask for tissue biopsy, don't just take a piece of tissue from the top and send it to us. First, you usually take biopsy from the wound toilet. So you do the initial debridement and do a proper cleaning to remove superficial debris. Then you take a deep tissue sample from an area which you can see infected by your naked eye. That is the best sample we need to find the true microbial load and the presence of invasive pathogens. Then the blood, that is the best sample you can obtain. Then the wound fluid sampling, aspirated samples. When a copious amount of fluid exists, sampling by needle aspiration can be employed. Used in these situations, you can use it safely. Used to sample deeper pockets to fluid beneath the superficial debris. The most useful procedure for sampling purulent phloem from intact cutaneous abscesses. And in cavity wound, mostly in the pressure sores, you can irrigate with sterile normal saline and gently massage to provide wound fluid for aspiration. In these manners, you can get aspirated sample from wounds. And the wound swabs, the most frequently taken samples, that is cotton tip swabs, to sample superficial wound fluid and tissue debris. Actually, when you can't take a tissue or a wound fluid, if there are no other way to get it, we just transfer it into wound swab. That is also in the same purpose, that means to sample the superficial wound fluid and tissue debris. But you need proper superficial cleaning with sterile normal saline, because I told it's always contaminants and always colonized flora there. To remove them, what I ask is with sterile normal saline, you just thoroughly clean the superficial area, and then you take a proper sample from an infected area, which you can probe the wound swab into a deeper areas and rotate and take a swab. That is the best sample after thorough cleaning. If a swab is taken inappropriately, that means prior to wound cleaning and removal of devitalized superficial debris, the resulting culture has been considered to reflect only surface contamination and colonization and provide misleading or useful information. That's why I told you earlier. And aspirates of purulent fluid and tissue samples are preferable to swabs. Always aspirate purulent fluid or tissue samples are preferable to swabs, because superficial wound fluid and tissue debris obtained in wound swab display a full spectrum of the wound aerobic and anaerobic flora, and some of which may be not involved in the pathogenesis, and some of which may not be. Because if you take just swab and wound, if you just swab a wound and say it involves the whole microflora, full spectrum of microflora, aerobic and anaerobic flora, sometimes some of these may be involved in pathogenesis, and sometimes some of may involve not in B. So we are in difficulty to identify who are the pathogens truly involved in pathogenesis. And there's advantage of aspirates, because aspirates will maintain the condition for viability of the organisms, that is moist and reduced environment. And all procedures involving sampling should be performed with strict aseptic technique, because to prevent addition of additional microflora to the sample we take. And the specimen transport, because there are a lot of microorganisms there. If you keep delay in sending, they tend to overgrow there. So the ideal time is as soon as possible to the microbiology laboratory. That is ideally within 1 or 2 hours. Swabs, usually it's susceptible to desiccation, and if you keep it there for some time, exposed to oxygen, so in that case you need to send in transport media, the MS media, which we don't have in Sri Lanka, because if you keep the swabs for some time, when it goes into desiccation, the organism will die, and if it exposed to oxygen, the anaerobes die, because anaerobes oxygen are toxic, lethal to anaerobes. And the storage condition of the swabs is at room temperature, because it is appropriate to maintain aerobic and anaerobic environment for microorganisms. So you need to keep it at the room temperature if there's any delay, but it's best to send within 1 to 2 hours. Then analysis of wound specimen in microbiology laboratory, which I didn't go into detail because it's not that important for you all. These are the main methods we do: this gram stain and culture and ABST. This gas liquid chromatography analysis is so advanced, usually do in research labs. And then the next part, how to control a microbial population in wounds. That's basically how to manage the wound in terms of microbiological aspect. The controlling the microbial load in the wounds is a vital factor in minimizing infection. It can be achieved mainly by giving systemic antibiotics. Mainly we recommend systemic antibiotics to the acute wound, because primary purpose is to treat the infection. And also we can give, we recommend for you all to give prophylaxis during surgical as surgical prophylaxis. But they found out the half of the all antibiotic prescribed by us is more go for surgical prophylaxis. But the pathetic situation is, I know most of the time we don't give it in a proper time to take the effect. So ideally what they recommend is you have to give the surgical prophylaxis 30 to 60 minutes before knife skin. That means before the skin incision made by the surgeon, 30 to 60 minutes before you have to give this surgical prophylaxis. The purpose of giving surgical prophylaxis is at the time of doing the skin incision, there should be adequate skin level of the this antibiotic should be in the therapeutic level in the tissue to counteract whatever the microbes come to the surgical site by our own skin flora and from the environment. Because if you give not given on the proper time, it will stay in the blood, but it doesn't come to the tissue via excised. So no point of giving surgical prophylaxis if you don't give it in the proper time, because there's no benefit for the patient. It doesn't reduce the surgical site infection, which is the purpose of giving surgical prophylaxis. and it added to antimicrobial resistance. Because I heard in most of the elective sections, they give after the baby's delivery, because they were worrying that there's anaphylaxis and then some problems occur for the child. In that case, better not to give, because you have already do the skin incision, already the uterus is open, so everything has been done. Then after doing everything, you just give, for basically to satisfy yourself, not to satisfy to the patient as well as to prevent surgical site infection, because it's we use huge amount of antibiotics. This antimicrobial resistance is a global threat nowadays, so we have to be very careful when we use antibiotics. So always stick to the purpose to get the true benefit, otherwise it will be disastrous than giving a true effect. The most uncomplicated surgical or traumatic wounds heal normally without the need for proper antimicrobial treatment, but involvement of foreign material such as sutures, dirt, grafts or prosthetic devices may increase the risk of infection in clean wounds. So usually if it is a clean surgery, you don't want to give surgical prophylaxis, but the problem is if there's involvement of prostheses, any grafts, many suture material, there's a risk of infection. Because of that, there's some effect on giving prophylaxis in these situations, even though they are clean surgeries. And surgical wounds that are potentially heavily contaminated, like gastrointestinal and gynecological surgery, and severe traumatic wounds that are heavily contaminated with exogenous microorganisms, antibiotic prophylaxis is definitely effective. And we recommend in these situations as it is a routine procedure. And for surgical infections are always polymicrobial, so aerobic, anaerobic, both aerobes and anaerobes are account for the infection. So when you choose the antibiotic, you have to cover both. And chronic wounds, I told throughout it's polymicrobial, aerobic and anaerobic. So when you select antibiotics, always you have to select which is appropriate to both the aerobic and anaerobic microflora. And the complementary therapy is the adjunct therapy to improve wound healing other than these systemic antibiotics, that is the wound cleaning and surgical debridement. Because what is important of it is it assists antibiotic treatment to reduce the microbial load, because if there's a large amount of microbe, the amount we deliver to the tissue there may not be enough to counteract with the huge microbial load. By doing wound cleaning and surgical debridement, you remove a significant amount of microbial load in the wound population. Then the antibiotic can easily act on the remaining microorganisms there. And other opportunities, enabling better penetration of antibiotics to where they needed. Because if there's a lot of slough, a lot of necrotic area, always this blood supply is poor and the penetration of antibiotic is poor. So if you remove all these debris and expose the perfused tissue, it allows the antibiotic penetrate well to the site and it will promote healing. So the wound cleaning and proper surgical debridement very important as part of wound management apart from antibiotic therapy. And the delayed wound closure. This delayed wound closure in certain situations allow time for antimicrobial therapy to reduce microbial load, without which healing may not progress, and avoid the contamination of blood clot in tissues, which is ideal for microbial growth. Because if you do the wound closure earlier, sometimes you close the wound with large amount of microbial load, so it will definitely cause the wound infection. So you should keep it open for sometimes antimicrobial reduce the microbial load, and then go ahead with the wound closure. And also if you close it early, there's a lot of fluid collect and the blood clot bleeding is there. The blood clots and the tissue debris are very good nidus for bacteria. They allow good microbial growth. So you should allow the blood to drain and whatever the pus and these tissue debris to drain out to reduce microbial load. When the times come to wound to a level the wound is fit for suturing, only you have to go ahead with secondary suturing. And another area which is very debatable in wound management, topical antimicrobials in wound care. Those are topical. There are topical preparation with antimicrobial activity to use in wound care. There are two preparations: topical antibacterials and the topical antiseptics. Topical antibacterials, as you know, these silver sulfadiazine, fusidic acid, metronidazole, bacitracin, polymyxin B and neomycin ointments. And the topical, what is topical antiseptics? Antiseptics are chemical agents that are potentially toxic to both microbial cells and host cells. Their use is limited to topical application to wound and intact skin. These are not antibacterials, they are chemical agents. They kill both microbial cells and the host cells. So because of that, you have to use it carefully in certain type of wounds, and may sometimes to clean intact skin we use. Those are we call topical antiseptics. Example, sodium chloride, that is normal saline, and chlorhexidine and povidone iodine. And there's a benefit of topical antimicrobials because it has the ability to deliver high local concentration of antibiotic irrespective of the vascular supply. I told this antibiotic delivery is always depend on the blood supply to the site of the wound, but because we apply it locally irrespective of the blood supply, it deliver high concentration. But and it also avoid the adverse effects of adverse systemic effects of systemic antibiotics, and it induce low incidence of resistance, especially the antiseptics. It results low incidence of bacterial antimicrobial resistance, but when you use antiseptics, it can be toxic to human cells and it can cause enticization, so you have to be used carefully. And although topical antibiotics, I told they are selectively toxic to bacteria rather than the human tissue, not like antiseptics, but they are likely to induce bacterial resistance. Like systemic antibiotics, topical antibiotics also can induce bacterial resistance. In that case, we promote to use antiseptics more frequently topically than antimicrobials in treatment of wound care. But however, prolonged antiseptics may compromise host tissue viability. So because of that, so it can be counteract. There will be a counteract effect of promotion of healing induced by the antibacterial effect. So because of that, when you use antiseptics, you have to use it carefully, not for a prolonged duration unnecessarily, because when it comes to the granulation tissue, it has a toxic effect there. So you have to use carefully. And then the next wound bed preparation, that is also an important concept in terms of skin grafts. So proper wound bed preparation. So in terms of microbiologist's point of view, how we can involve in wound bed preparation, that's why I include this slide. We always promote to use topical antiseptics in the situation. These are the antiseptics we use. Hypertonic saline, which is remove exudate and slough very well, and to remove colonization, that is 0.5 to 1% acetic acid we use for Pseudomonas aeruginosa, and the betadine more effective for gram-positive organism like MRSA, and it has antifungal activity as well. And you have to avoid in granulation tissue form because it disturbs granulation, and chlorhexidine also have more gram-positive cover, but used for decolonization. Normal saline, it has a very good gram-negative cover, better once the granulation tissue forms because it doesn't disturb granulation tissue. And because this chronic non-healing wound, if I talk about chronic non-healing wounds, it has become a chronic non-healing wound because it's stuck in the inflammatory phase. We need to push them into the proliferative phase for the healing. If no progression of wound and no associated septic features, if there's no progression of wound and no associated septic features, systemic antibiotics are not necessary. In this situation, can manage with rotational antiseptics. But many antimicrobial, these chronic non-healing wounds, many antimicrobial resistant strains are isolated frequently in chronic wounds. So antimicrobial resistance is a big issue. So we have to find alternatives. The promising method, which I also have experience about bee honey, and this is an actually unpublished data which have done a study on bee honey, evaluation of microbiological properties of bee honey found in Sri Lanka among microbial species isolated from non-healing wounds. This is unpublished data. I thank to Jagat for giving me the ethical clearance to go ahead with study. And we assessed 70 samples. None of them grow bacterial and fungal growth was not noted any of the samples. Those we can assume they are sterile. So can go ahead. And these resistant organisms, we found there's a significant sensitivity for these resistant organisms in this bee honey. So there's a promising effect. Still we are not in the commercial stage, so we can have a hope to use in wound care. And this I just include the pictures. Chronic colonized wound. These wounds, if you see, there's no signs of systemic infection. There's no signs of associated infection. No need to give either topical or systemic antibiotics. You can use with rotational dressing to remove the debris and whatever the colonizers. And this is another wound which no need to give antibiotics. You can manage with antiseptics. And other measures like pressure reduction, offloading, and vacuum as vac drains. They easily remove exudates and can granulate easily when you remove exudate. And another important factor to talk about the application of skin grafts, because that is why the wound bed preparation is important. A need to vascularize wound bed. And in the this microbiological point of view, these if you sometimes when they ask to send us wounds up, and if there's a growth, they don't do cultures because they don't do skin grafts. You don't want to wait until the microbial population is zero in a wound bed to graft, because there are wound colonizers which increase the risk of grafting like MRSA and Pseudomonas aeruginosa. But if I show you the next one, this graph you have seen is nicely accepted. But when you take a swab, this is the swab grown, there's a coliform growth, huge coliform growth. But we ask them to go ahead with grafting because it's not an organism usually reject grafting. But if you wait until this wound swab to become no growth, it will again and again get recurrent infection and you will never have to go for grafting. As well as you cover the skin with a clean graft and the graft is nicely accepted, the wound heals. So when the wound bed is okay, if there's no organism risk of graft rejection, you can go ahead with grafting. And the last part, the infection control. Because if I don't talk about infection control, I'm not a microbiologist. That's why I thought I just include 2 slides. And what is the purpose of infection control in wound care? To control the dissemination of potentially pathogenic members of the wound microflora into the surrounding environment in order to minimize the opportunity for cross-infection. That means we have always, when we do the wound care, I told wound environment, lot of microbes are there. So you have to do proper infection control to prevent disperse of microorganisms to the outside, to getting outside contaminated, the hospital environment to contaminate, and it prevent transmission from patient to patient via direct and indirect contact. So wound dressing, we always ask to use proper wound dressing to prevent physically dispersal of pathogen to the environment when you remove dressing, airborne dispersal of microorganism by at the time of dressing removal, and also to reduce infection rate. And you have to do proper dressing and always cover infected wounds with proper dressing. And when there's pathogens like MRSA, group A strep multi-drug resistant organisms, you have to use single room or cohort isolation to prevent outbreaks. And this contact precaution and barrier nursing always be asked to use when there's multi-drug resistant organisms in a patient. And thank you. And this is the hospital I work, and all these pictures of the patients and patients are the patients whom I am treated in my hospital, and all the culture paste are the wound samples we got from those patients. So thank you for giving me the opportunity to deliver your proper lecture.